That's okay. Just let me go. All right. Thank you very much for inviting me. Dr. Wilkins Ho invited me. I'm Patricia Johnson. I'm an anesthesiologist practicing mostly at Royal Columbian Hospital. And so when I was asked to give this talk after talking to Dr. Wilkins Ho, I thought, what qualifies me to talk on this subject? So starting out, I am a Royal College certified anesthesiologist, so that does give me some basis to speak on that. As I mentioned, my primary practice location is at Royal Columbian Hospital, where we do ECT treatments 3 days per week, usually 3 patients each day. And the anesthesia for those procedures is provided by a smaller group. It's not provided by our whole group. There's about 10 to 15 of us which rotate through the practice of providing ECT anesthesia. I also work at Eagle Ridge Hospital, but we do not do any ECTs there. And I am also the medical director of the New Westminster Surgical Centre, which is a non-hospital accredited surgical facility where we do both inpatient and outpatient ECTs. We are currently doing 2 days per week there. I did look at our numbers, and for the last year at New Westminster Surgical Centre, we are doing, our average is probably about 38 procedures a month, but we have done as many as 50. And at Royal Columbian Hospital, we're probably doing somewhere between 25 and 30 patients per month. So, and in my own practice, I did look at my numbers for 2013. It's a little bit skewed because they changed some of the fee codes, but I'm probably approaching about 200 ECT procedures per year. So I think I am able to speak somewhat on ECTs. So I'm going to focus on 3 main areas. Dr. Shabbatz gave us a very comprehensive review this morning on the medical evaluation of patients prior. I'm just going to speak very briefly on what I think is the value of an anesthetic consult. I want to talk a little bit about what I think is really necessary to provide safe anesthesia care for these patients, because depending on what facility you work in, you will be providing them in many different locations. So I just want to say what are the basics. And then I just want to talk about a little bit about the actual, medication, the actual anesthetic. So we can talk about that a little bit. So this is from a paper. There's a list of references that I sent. Perhaps they can email them out to you. But this looks at how to do a medical evaluation of the patient. Gives kind of an algorithm. And this is from the same paper. So this is a review paper from the Journal of ECT, just published last year in March of 2014. So it's got the approach to the pre-ECT medical evaluation. And you can see it's quite comprehensive. And like I said, Dr. Shabbatz would have covered a lot of those this morning. But I wanted to just say what I think are the specifics that an anesthetist can bring to that pre-anesthetic evaluation. Well, first of all, we can review what previous anesthetics the patient has had. If you get an internal medicine consult to look at their overall medical comorbidities, they will not really look at that aspect of the patient's pre-medical condition. And we can also look at whether they've had ECT before. We will often look at the old ECT records and look and see what they've had done before, whether there was any noted side effects. So that's something that we can do quite uniquely. We will evaluate the airway, obviously, because that is something that we often need to manage during the course of ECT treatments, because we are putting these people to sleep. We are paralyzing them. We do need to breathe for them for a certain length of time. So that is something, again, that we are uniquely able to do. We can review the medications they're on, not so much those psychotropic medications, but all those other medications that Dr. Doyley mentioned as well, the antihypertensives, the anti-reflux medications, and we can recommend which ones we think should be held, or which ones should be continued, or which ones need to be modified prior to their treatment. We can evaluate, again, their coexisting disease and how we think that will interact with their treatment. We can also plan the optimal location for their treatment, especially when you're in an area such as ours, where I do procedures at Royal Columbian Hospital, and then we also do procedures at the non-hospital facility, there are some patients, because of their comorbidities, where it is not optimal to do their procedure at the outpatient facility, but it would be better to do it at the inpatient facility just because of the infrastructure that we have in place. So that is something that we can certainly help with. We can spend time actually talking to the patients about what's involved with this anesthetic. Again, that's something that as an internal medicine consultant, you may not be able to tell them, what's actually going to happen. You're going to have monitors put on, you're going to have an intravenous started, we're going to give you some oxygen, you're going to have the medication, you're going to go to sleep, and we can talk to them about some of the side effects. And we can often alleviate some anxiety that they have, because of course many patients are going to have seen information that is not in favor of ECT, and a lot of them will still remember, some of the less favorable aspects that have been in the media before. So I think that has certainly been shown to be beneficial to most patients, is to be able to talk to an anesthetist and know there's somebody there that is going to make sure that they are asleep. So then again, I just want to talk a little bit about what I think is the essential equipment that you need in any location in which you're going to provide anesthesia care. As I said, these patients are going to require ventilation, so you're going to need to make sure you have an oxygen source. You have to give some way of giving positive pressure ventilation to these patients. You have to be able to suction them. You have to have a crash cart available. So if you are anywhere that you're not on the same floor or intimately associated where there's another crash cart, then you should have a standalone crash cart. You should not be reliant on the one that is, 2 floors above that you can bring down if something happens. You should have one there. Again, you should have a malignant hyperthermia cart. Succinylcholine is one of the triggers for malignant hyperthermia. Even though it is a rare condition, it is still mandated that in any location in which we are going to be giving triggers, that a malignant hyperthermia cart should be available. And since treatment is usually needed to be started immediately, again, you don't want it to be a couple of buildings away before you would have your malignant hyperthermia cart. And my feeling is that the anesthetist should be as familiar with the drug cart and the airway cart in whatever location they're working in. So if I'm doing ECTs or whether I'm in the operating room, I want to have the same equipment. I want to have the same familiarity with my cart so that if I need a drug quickly or I need some adjunct quickly, I know where it is. I don't want to have something that's put together kind of ad hoc because we think we might need these few drugs. It's better to have the same equipment that I'm familiar with all the time, because when things go bad, you want to be able to deal with them very, very quickly. In terms of the monitoring, because these patients, again, are receiving the general anesthetic, they need monitoring, including ECG, non-invasive blood pressure, pulse oximetry, and I believe now that capnography availability is essential. So this is the ability to measure end-tidal CO2, and that will enable us to ensure that the patients are being adequately ventilated. And as I mentioned, you have to have the anesthesia cart with full drug supply, airway equipment, and intravenous access. And you probably should, if you are in a standalone area, have a secondary method for securing the airway. Most of us use, as you're familiar with, the laryngoscope, which is in many cases still the primary method, but if you're dealing with patients, you should have at least one secondary method in case that one fails. If you're in a setting where you're in a standalone area. If you're in the operating room, then all that will be available, but if you're giving ECT in an area that it doesn't have that, then you should have some secondary way of securing the airway. The physical layout, I'm sure you've all seen different areas. You need to have something for the patients to change. You need to have some sort of pre-procedure checklist where you can check their vitals, ensure that they are MPO. You need to have the area where you're going to give the procedure, where there's full monitoring, but also enough room. It's not uncommon sometimes sometimes people try to get procedures done in smaller areas, and that's certainly been my situation where they've decided they want anesthesia coverage for something, and we're in a shoebox and I can't even get to the monitor. So you want to make sure you have enough room where if something does happen, that the anesthetist and the rest of the team can can get to the patient and get to the equipment. If we need the crash cart in the room, can bring it in the room, so that we're not trying to do this in a space that's not adequate. And then you also need a post-op recovery area where you can monitor the patients. You need to be able to monitor these patients post-operatively. Some centers will do it where the patients will stay in one site and the team will rotate around and the patients will have their procedure and recover in one area. Certainly when we do that in our recovery room at Royal Columbian Hospital, that's how we do it. The patients have their monitors placed, they have their procedure, then they are monitored in that same spot. At the non-hospital facility, we actually do the procedure in the operating room. They are brought in on a stretcher, they're put on the monitors there, they get the procedure, and then once we feel that they are stable, we transfer them to our recovery room and they are monitored again by a post-anesthetic nurse at that time. So now just talking about the anesthetic, what are the key parts of an anesthetic? It's really quite simple. We need a hypnotic, we need something to make these patients unaware, we need some muscle relaxant to modify the motor part of the seizure, and then we need our adjuvant drugs, which are usually dealing with the side effects of the treatment. So, as has been mentioned, antihypertensives, antiemetics, analgesics, and sometimes anticholinergics. So it's really quite a simple recipe that we need, but we want these drugs to have some certain properties. So with our hypnotics, we want the drug to have a fairly fast onset. We want it to have a good hemodynamic profile. We don't want to be able to give it and have the patient very hypotensive or very hypertensive. We want there to be minimal changes in the seizure threshold so that we can facilitate the treatment. We want the patients to have a smooth emergence. We don't want them to be very agitated or delirious, which could be secondary to our hypnotic agent. It has to be readily available, and that has been one of our key problems in the last few years. Is the mainstay of hypnotic agents for ECT used to be barbiturates, but they've been increasingly difficult to get, and thiopental now is unavailable, and methotrexate is available under special dispensation, so they're getting more difficult to get. So many of us have moved now to propofol, which is the agent that we use for most of our surgical procedures now. But other agents can also be used, such as etomidate, ketamine, and even inhalational agents. There are some reports of using inhalational agents for ECT. But as with most things, we're going to use ones that are familiar. And so, like I said, most of us have gone to propofol, although methotrexate can be available, and then these other agents can be used in certain circumstances. So the benefits to methotrexate, it does have a rapid onset and redistribution. It's supposed to have less suppression of the seizure threshold than other barbiturates or propofol, but there is the supply issue, so it can be difficult to obtain. Propofol is widely used now. It has very rapid onset and offset. It has very good side effects in that the nausea and vomiting is very low, and that's especially important if you're doing ECTs on young patients because they will tend to have much higher incidence of nausea and vomiting, so if you can use propofol, that's better. It tends to have quite good favorable hemodynamics. It can increase the seizure threshold, but it is very readily available. Even when there was a shortage in the U.S. about 18 months ago, but Canada was somewhat, we didn't experience that because our supply chain was not the same as the U.S. So we really have not had a big interruption in our propofol supply. So there have been lots of studies looking at various induction agents to see whether one is better than the other in terms of seizure threshold. So there was a meta-analysis. They looked at 706 patients, and they felt that there was a shorter seizure length with propofol, mostly under 30 seconds with propofol, whereas over 30 seconds with methotrexate. But in this meta-analysis, they could not find a true difference in outcome. Now, of course, they're measuring lots of different outcomes. You know, there can be a lot of heterogeneity in all of these studies, but it doesn't look like there's a lot of outcome. There was another study where they actually tried to get rid of some of that heterogeneity. So what they did was they actually did a retrospective review of multiple patients that had undergone multiple courses of ECT with different induction agents to see if they could find a difference. And so they went back to 1992 to 2008. They found 48 patients, which isn't a huge number. And they actually looked at the number of treatments required per course, the changes in the depression rating scale, and the hospital length of stay. And the only place where they could find a difference was in the right unilateral treatments. There were statistically fewer treatments with methotrexate, 5.3 versus 6.5. So, I mean, it's statistically significant, but I would think the numbers are still fairly small. And this is just showing the numbers. So, in this situation where we do have a situation where we don't think that the seizure thresholds are adequate, where we think that the patient is not getting adequate seizures that are leading to good response, what can we do to improve on that? So there are a few things that we can do. One of the things we can do is we can use a drug called remifentanil, which is an ultra short-acting narcotic. It is almost completely eliminated once you stop giving the drug. It's metabolized almost completely by cholinesterases, so it doesn't really stay around at all. It's used quite extensively during neuroanesthesia and other procedures where we don't want to have a lot of narcotic around. It has very good hemodynamic profiles. But importantly, you can use it to reduce the amount of propofol that you need in order to get loss of consciousness. So you can probably reduce your propofol dose by about a half. And if you look at a lot of the studies, many of the studies are using between 1 and 1.5 milligrams per kilo of propofol. Of course, we titrate it to the effect in the individual patient, but a lot of the studies show that if you use approximately 1 mic per kilo of remifentanil, you can maybe reduce your propofol dose by up to 50%. So that may give you a better seizure in some of those patients. You do have to be careful because in elderly patients, you have to reduce the dose because it will make patients apneic. Now, you are paralyzing them anyways, but in elderly patients, you have to be careful with the dosing. You might have to reduce the dose in the elderly patient, and it does increase nausea and vomiting. So many of the patients might require something for nausea and vomiting if you're going to go that route. And it may increase the recovery time depending upon how much you've given and how quickly it wears off. Because we're usually not using any narcotic, so when we're using this, you may notice that they might take a little bit longer to regain their respirations. So just to keep that in mind. The other thing that can be done is you can use ketamine, and ketamine has been used alone for the induction of anesthesia. And there have been even some studies that ketamine in and of itself is an antidepressant, even just given in one dose intravenously. So there have been studies looking at both ketamine to improve the efficacy of ECT, but also ketamine to improve the seizure. So it may be a little bit hard to sort those out. But if you use it alone for induction, the problem is that you get a lot more adverse effects. The patients can become quite delirious. They can become agitated. They can have more hypertension. So there's most people, if they want to try and use it, try and combine it with propofol again to reduce the dosing. So that's another adjunct that could be used. And the dosing is probably close to maybe 0.5 milligram per kilo. You could probably start with that. But you can, and then you can decrease your propofol dosing. But if you use it without propofol, you're going to get agitation, and you have to be careful in your older patients. Just talking about muscle relaxants, currently succinylcholine is still the drug of choice due to its short onset and duration. The dosing really depends. We try to individualize the dosing. People with larger muscle masses need larger doses, so there is a bit of a titration at the beginning, just like with propofol. In cases where the drug is contraindicated, which are not that many, then we may have to use another agent, one of the non-depolarizing agents. The only one we really have available now, we have rocuronium and we have a conjurer of it. It has a duration of onset that is relative to its dose. So if we want it to work quickly, we have to give a big dose. The problem with that is that it lasts for a long time. And so if you're going to use a large dose, then you'll need to support the respirations of those patients until that dose is such that you can reverse it, which may take 10 or 15 minutes. You may be quite a while. You may have to actually give that patient, after the ECT treatment is done, you may actually have to give them some more hypnotic, because you don't want the patients to kind of be awake and partially paralyzed, because that's very distressing for patients. Eventually, there is an actual specific inhibitor for rocuronium called sugamidex, which has been available in Europe for approximately 5 years, but is still awaiting both FDA approval in the US and in Canada. So we don't have that yet. Once we have sugamidex, we can reverse rocuronium very rapidly. So that will be very good, but we don't have it yet. So if we're using non-depolarizers, we just got to be careful. We've got to make sure that we can support those patients during that time. We have the adjuncts to treat cardiovascular effects. I usually do not use anticholinergics on a regular basis, and I rarely have to treat any bradycardias. We're mostly treating hypertension, and we're mostly using beta blockers. So we also continue the antihypertensives on the day of the procedure. Our practice usually is, if we recognize somebody who needs a antihypertensive during their treatment, is that they'll get that drug first, give it some time to work, and then we'll go on with the induction. Post-treatment, you usually don't require antihypertensives, but you can sometimes identify a patient who probably has chronic untreated hypertension, in which case those patients should be referred and be started on an antihypertensive. As I mentioned, the incidence with nausea is low, and we can use ondansetron either pre or post-operatively, pre or post-procedure. Dr. Unger?
Hi, yeah, thanks. I've just heard different things from a few different anesthetists that I've worked with at RCH about use of anticholinergics for patients who get significant bradycardia or even brief asystoles. Some kind of the mindset that, if it's transient, they're not going to really be very concerned about it, and others preferring to have the anticholinergic on board beforehand. What's your take on that?
Okay. Well, like I said, my personal take is that I can't remember anybody in the last year who I've had to treat with an anticholinergic. But certainly, I guess you would have to again look at what the premorbid condition in that patient was. So if it's a young, healthy patient that has no other concomitant medical disorders, and you might have a short run of asystole or even a short run of bradycardia that doesn't also be accompanied by any significant hypotension, then I would probably leave it untreated. If I had somebody who had, maybe significant cardiac comorbidities where I would think, significant bradycardia would be a problem, and especially if it was associated with hypotension, then I would probably treat it. Again, you have to be careful then that you don't make them too tachycardic or too hypertensive. So I'd really have to look at the individual patient. But if it's a short run in a healthy patient, in my estimation, most of those return quite quickly. We have had a few patients where, they've remained bradycardic even though they're otherwise stable, but bradycardic as opposed to what their initial heart rate was when they came in. And those ones we've had investigated just to make sure they don't have some underlying conduction abnormality that is being unmasked by the ECT. Does that answer your question? Okay. So like I said, ondansetron, if you have somebody who continually becomes nauseated at their ECT, then it's probably best to pre-treat them with oral ondansetron. You can order that orally, and we can give it intravenously afterwards. Most of the headaches and myalgias will respond to simple analgesics. And so when I'm giving treatments, especially somebody who's coming for a new series, if I've seen them over and over again, which I often do, I will say to them, how was your treatment? Did you have many muscle aches? Or headaches. And if they say they do, then what I'll do is I'll start them on acetaminophen and an NSAID right post-treatment. So within half an hour of post-treatment, and then I'll tell them to go home and to continue usually for about 24 hours with acetaminophen and a non-steroidal, and that will usually treat most of the patients. So I'm just going to summarize what I've spoken about here. So I think you should use the lowest dose of hypnotic to obtain loss of consciousness, so you can titrate it to effect. In the setting of poor seizure quality, in consultation with the treating and the ECT psychiatrist, we can look at what other concomitant medications the patient may be on. Maybe it's benzodiazepines. If all of that's been eliminated, then we can look at our dose of propofol, maybe that can be reduced. We can add in, you can consider some of the adjuncts that I've talked about, and we can consider hyperventilating. So again, it's an approach where we can all together look at what are some of these strategies we can use to improve the seizure. And so just in conclusion, I think that if you are, having your patients come for ECT, I think that an anesthetic consult does confer some added benefit over and above an internal medicine consult. I think if you're going to be doing these procedures, you need to make sure you're in an environment that's safe for the patients and is good for all the team members to work in, especially for anesthetists who, have to go to other sites, make sure that we have all the equipment that we need, and that the treatment efficacy needs to be determined individually in each patient, and that there are anesthetic modifications that we can do that may be beneficial to help with the overall treatment efficacy in an individual patient. So thank you. I'll take any other questions that anybody has. Yes. I don't routinely use a nerve stimulator, no. With succinylcholine, it's really not required. If you were going to be using non-depolarizing muscle relaxants on a routine basis, or if you had a patient that had to have a non-depolarizing muscle relaxant, so rocuronium, then you would probably want to use a nerve stimulator, because there's no real way of telling when it's reached its peak. So in that case, you would probably want to use a nerve stimulator. But I don't even have a patient right now that's getting non-depolarizers. Yes? Yes. Well, I can tell you, we have a protocol at Royal Columbian Hospital for using IV ketamine for postoperative pain control. So we have written a protocol for patients actually to go on a ketamine infusion, and we can actually monitor that on the ward. So I believe, I didn't delve too deeply into the treatment for depression, but I believe the treatment for depression is it's not like an infusion for 2 or 3 days. I think it's a short, like a dose. Yeah. 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 Yeah, I think that the monitoring for the monitoring for ketamine is not it's not doesn't require a lot of extensive monitoring. So, but what we do is, like I said, our protocol is for actually patients going on a ketamine infusion. So we actually monitor them for about an hour in our recovery room after we started. So if you were going to give a single dose, then that's probably all you would need, because I think the dose is infused over about an hour, I think. I'm not sure of the protocol, but you would probably have to write a protocol, and then you would have to have them in some sort of monitored setting, whether you could do it in your recovery room, you could do it in if you've got a step-down unit, you could do it in that. I don't think that the monitoring would be really terribly difficult to arrange, as, things are difficult to arrange, and it doesn't require an anesthetist to actually give the drug. It can be hung as an infusion in a mini bag. So I think your biggest challenge is going to be finding a location in your hospital where they are willing to do the monitoring once you've written the protocol. So, because like I said, we have patients on the ward on infusions. So, are there any other questions? Oh, sorry. Right? Well, whenever the challenge, of course, just like yourself, is when we're starting a treatment and we're kind of looking at the patient, we're using our experience to say, okay, this is a 70-kilo, 50-year-old. So, but I think most of us, what we're doing is we're actually giving propofol until we see loss of consciousness. And then, because when you're doing your titration, we often sometimes have to give a second dose. In our institution, most of us will follow the previous person's treatment unless we've written a note. So, for example, I did a treatment yesterday where they felt that the previous treatment, the seizure was short. So I said, okay, I'm going to try to reduce the propofol in this patient. So I've brought down the propofol a little bit to see if we can get a better seizure. And so then I wrote a little note on there saying, maybe try to reduce propofol some more, or somebody may say try to increase propofol. But in our institution, most of us are using the same doses unless somebody has written a note to say you should be changing that because of either the seizure or, occasionally we'll have a patient where, we've given too much and they take a long time to wake up. But and it's interesting because coming at the outpatient facility, we got a lot of patients coming from other sites. They may have already started their ECTs at another site and now they've become an outpatient, so now they're coming to have it done as outpatient. And I'll sometimes look at some of the dosings and I'll think some of the dosings are actually quite high. Because I think, at least in my group practice, we tend to be fairly low dosers. Because I'll see some quite elderly patients coming and I'm going, whoa, that's a lot of propofol. So I'm not sure if it's just, people who are not very familiar with ECT all the time and are a little bit worried they don't want people to be aware. So we tend to follow the previous person unless there's something been changed. But you're right, I do see sometimes what I think are quite high doses, and it may just be an experience, I don't know. Anything else? Okay, thanks.
So it's my pleasure to introduce Dr. Caroline Gosselin. She's a clinical professor in the Department of Psychiatry at UBC. She's active in research, teaching, and the practice of ECT, has conducted ECT workshops for the past 13 years at the CPA annual scientific meeting. She's the co-chair of Connects, which is a group who have conducted Canada's first national ECT survey and are now in the process of writing national ECT standards. Dr. Gosselin is a contributing author of the BC Guidelines for ECT and has conducted the site reviews for ECT programs at Canadian hospitals. She is also chief examiner for the Royal College Physicians and Surgeons Psychiatric Examination Board. Many years ago, I embarrassed her by introducing her as the Queen of ECT, and I will do so again.
Does this go off, Michael? Is it off?
And you should be live now.
Better now. Sorry, it wasn't even on. No, it's green. Anyway, I was just complimenting this beautiful hall and the beautiful acoustics. Wow. So I'm not the Queen of ECT at all, and Mike always promises he will never ever say that sentence again, but somehow he always does. It's a pleasure to come today and to talk with you about the actual nuts and bolts of an ECT course, which is endlessly interesting and always a patient by patient and even treatment by treatment decision. We talk about ECT as an art, and I can certainly say after years of doing ECT that I am still constantly learning and finding surprising situations in ECT that we all end up learning from. So we're going to talk in the next hour about electrode placement options before us and some dosing strategies. We're going to review EEG interpretation and its application and how we make ECT decisions, and also just a quick review of the really core elements of safe and sound practice. The main goals always for ECT is to ensure medical safety. So I've put that as my number one goal, and I am always reminded that until the absolute last minute when we put our thumb on the stimulus button, we can still decide to not deliver a stimulus if something happens which is surprising and untoward and makes us decide, forget it, it's not safe. We're going to let the patient wake up and send them back to the unit and figure out what to do before we go back in again. And sometimes that feels like a very brave thing to have to do, but I've actually been in situations where in the last minute, despite pressure from everyone and even from within myself, that I've decided to not deliver a stimulus. And the number two thing, if things are safe, is to make sure that we give ECT as a balance in a way that minimizes cognitive side effects, because so much of that is iatrogenic, and it's that gives ECT such a bad name. And at the same time, to optimize patient recovery and get patients who are suffering so much better as quickly and out of hospital as quickly as we can. So that's the task always before us. We have these beautiful new computerized devices in the last 15 years, which no longer deliver the massive electrical current from the old sine wave devices that I trained with, and that give brief positive and negative pulses. We adjust through our devices the pulse width, the current, which is the height of each pulse, the frequency, which is how close the positive and negative pulses come together, and then finally how many of those couplets of positive and negative pulses we deliver all together. And so in the literature we call that duration, or also pulse train is used. Those words are used interchangeably. And so our ability to adjust those dials and adjust those parameters and the morphology of the pulse has a profound effect on the outcome of our ECT. We can create a seizure which is completely useless. We know that now. And we can create an extremely aggressive seizure right from the beginning, which will result in symptom recovery, but also a lot of associated cognitive impairment. So the art is feeling so comfortable with our pulse width morphology and our outcome, and making sound clinical decisions treatment by treatment, exactly as we do with medications. We have several options for electrode placements. I've put them also in order of which they've come out. Initially bitemporal, then came right unilateral, and actually left unilateral after that, and now also in the last 15 years or so, an increased use of bifrontal ECT. Peter will have spoken about CONNECT's, our national ECT survey, which many people in this room have completed, and so your data is part of the CONNECT's data, and that has shown that the bifrontal ECT is really very widely used in Canada. The unilateral electrode placement is interesting. We're reminded that the brain doesn't have uniform excitability. The motor strip has the lowest intrinsic seizure threshold, and so theoretically one would think that where we place unilateral electrodes would be the optimal place to put electrodes, because this is the area of the brain that seizures most readily. The problem is that when the closer that electrodes are together on the scalp, the more shunting of electricity there is through the scalp, rather than electricity going into the brain. So there's a third of the current that we actually deliver is wasted. And so for that reason, there are Americans and other UK have, our colleagues in their policies have recommended that if we're going to do right unilateral or left unilateral ECT, that we use placements in which the electrodes are the furthest apart as possible. So for that reason, we're using the Delia position, right? Which are these, you create two intersecting lines between the trachea of the ear, you find a midpoint, and then another intersecting line, which is from the Nasion to the Inian. And where those two intersect, the electrode goes midpoint, but so a few centimeters down from that intersection, so that you're definitely over the right hemisphere. It involves parting of hair, it involves really good scrubbing, it involves abrasive gel, and I use a marker because I'm really lousy at estimating where that is. I think it's important to really create an accurate landmark where all of us, when we're giving ECT to the same patient, are putting our electrodes all together in that same, exactly that same place. Also, no one can see markers up there anyway, unless someone's bald. Then we just wash it off. So we're advised to not forget about left unilateral ECT. It's hardly ever done. I've never done it. Has anyone in this room ever done left unilateral ECT? Just out of interest? You have. You have not. Okay, so none of us have. And it kind of fell into disrepute when there were some studies that came out in the 60s that said it wasn't as effective. Richard Abrams took all those studies to task, showed that they had bad designs, showed that they weren't using Delia positions, and redid that work and found that those patients recovered just as well as the right unilateral. So the recommendations are that you could consider using left unilateral ECT, particularly in patients who have skull defects, who have shrapnel, who have something there in their right hemisphere that you're wanting to avoid. So don't forget about that. So for bilateral, this is the old-fashioned terminology. Basically, it means bitemporal. Current is diffused through all areas of the brain, just as in right unilateral. But the interesting thing is that in bilateral, bitemporal ECT, there is a significant higher current density throughout the whole area of the brain. And it is thought that that is the reason for which bitemporal ECT is more effective than right unilateral. And it's also not throughout higher current density throughout the whole brain, but also anterior to where the electrodes are, right? Which is, as Peter would have talked about this morning, the thinking of where a lot of the depressive etiology lies. Bifrontal was introduced, I think, in the 60s and scrapped. The electrodes were too close together. There were skin burns. The patients didn't get better. And then our group of Canadian colleagues in Kingston University decided to take this to task and did an exhaustive, meticulous 7-year study in which they had a huge cohort of patients who they gave bifrontal ECT to and had beautiful recovery. Their work indicates that those patients had the same recovery as patients getting bitemporal ECT, but with the lesser cognitive impairment similar to that of patients having right unilateral ECT. So this is the picture from that original article, which is kind of a strange picture, but it indicates the landmarks for the electrodes as the midpoint of the electrode being 5 centimeters above the outer corner of the eye on a sagittal plane. So those aren't the electrodes, those are the midpoints, those little circles, because the electrodes are actually much, much bigger, right? So just to show you here, the bitemporal, on this patient, you can see the midpoints of the bifrontal. Here is right unilateral, and here is the bifrontal placement, which is actually a very convenient electrode placement for most patients. So moving away from electrode placements and more into actually how to dose in ECT. These are the three commonest dosing methods that we find in the literature. There's the half-aged based method and the fixed high dose right unilateral method, and then the titration method. In the half-age method, applies for patients having ECT twice a week, bitemporal ECT. And the recommendation is to start the device with an energy level on your device, whatever it is, at half the patient's age. So the classic example that's cited is if a patient is 60, that you would set your machine at 30% of the output of that device, and then just gradually gestalt your way up or not, depending on how that patient is doing. The fixed high-dose right unilateral ECT, those patients get all their ECT right from the get-go at maximum capacity with an ultra-brief pulse width and an 8-second pulse train. And if there's no improvement after a few treatments, those patients are then switched to bitemporal ECT. And this is the method described by Richard Abrams in his book. And this is how some people do ECT. All the way through, regardless of age, gender, diagnosis, number of ECTs. They just set the machine at full tilt and deliver all the ECTs that way. The titration method came... Yes, sir. Can you push your button on your microphone, please?
Sorry to interrupt, but isn't the pitfall with that method that you may actually have a poor seizure due to having too much stimulus? Is there any validity to that?
We're going to talk about that.
Okay.
You may not get a poor seizure, but you're going to get a heck of a lot of unnecessary cognitive effects, probably. Okay. Depends on where someone's seizure threshold is. Yeah. So, which brings us to the titration method. So this is the work of Harold Sackheim from Columbia University. And as a young clinician, after a few years of doing ECT, with a beautiful, $20,000 MECTA device at my hospital, and the ECT clinician who taught me how to do ECT with that device, which was, she said, Carolyn, you begin by setting all the dials at 11 o'clock and do your first treatment. And then if they're not better, then you turn up the inside 2. And then if they're not better, you add the outside 2. And that's kind of how you work your way up. And that's how I did ECT for 2 years. So don't tell anyone. But those patients actually got better. But after a while, I started realizing there's got to be something better than this, right? And so then out came the APA policy, and then from the policy came the ECT training programs that were held at in the United States, South Carolina at Duke. And so I went to one of those and happened to be in that room when Harold Sackheim presented this work. And Harold Sackheim took a huge cohort of patients, divided them into 4 groups, and gave 2 of the groups right unilateral ECT and 2 of the groups bitemporal ECT. And within each of those groups, one group got very low dose ECT, just barely over seizure threshold, and the other he increased, I think, by 2 times or 3 times seizure threshold. And so these are his outcomes. This is the Hamilton rating scale for depression. So, and here is baseline. This says 6th immediately after the last in the 1 week after treatments. And so here are all those depressed patients with really high HAM-D scores to start with, and here they are a week after the treatment, and here they are at the end of treatment. And these are the low-dose right unilateral group, and Harold found that 17% of those patients recovered. And these are the high-dose right unilateral, and these are the 2 bitemporal groups. So the take-home message from this study is that it's perfectly possible to create a seizure that creates no improvement. And when he turned his PowerPoint off, there was just this deafening silence in the room. And I think this is the study that has changed how we do ECT. And out of this has come the titration method. So and I've just kind of summarized this here. If this is seizure threshold and we do a stimulus that's here below seizure threshold, we don't get a stimulus at all, right? And if we are giving a low dose, just barely over seizure threshold, we get a seizure, but we get this really poor EEG morphology, as opposed to if we are high enough over seizure threshold, you get this gorgeous EEG morphology, and it is coupled with clinical improvement. So that's this big part of what we do in psychiatry and ECT is focus on seizure threshold and this concept that you have to have sufficient neurons depolarized in order to set off that excitatory process in the brain. And seizure threshold, I've written it as this black line. It's not a black line at all. It's virtual. It's like blood pressure. Our seizure thresholds apparently change all the time within a day, from day to day, like our blood pressures, but also are predictably affected by some things. They're affected by age, as Heather said. As we age, our seizure threshold climbs. By gender, men have higher seizure thresholds than women because men have larger brains, thicker skulls. A seizure threshold is affected by anesthetic, so if you get a high-dose barbiturate anesthetic, that in itself may in fact impair the ability to create a seizure. The number of ECTs, so most of you know that for most patients, seizure threshold tends to climb. You have to write something on an exam, that's what you would write, that seizure climbs, right, within an ECT course. But it's very, very interesting to watch because it doesn't for everyone. And I think all of us have given ECT to patients with some absurdly tiny dose, right, hardly up the protocol, with people who have gorgeous EEGs who are immediately better and who continue to get better treatment by treatment and are finished at treatment 6 with some tiny dose. It's just such a gift when that happens. And then there are other patients whose seizure threshold just climb through the whole course, who need 15, 20 ECTs, and whose seizure thresholds you already are giving maximum dose that you can from your device by treatment 10. So then you have to start juggling other things that you can to try to keep eliciting seizures that are going to be beneficial and not just sitting right on seizure threshold. And
Gosselin.
Individual differences and electrode placement, right? So bitemporal requires more of a charge to actually induce a seizure.
Dr. Gosselin, could I just ask, you showed a picture, a figure a couple slides back with some really nice seizure morphology and talking about the seizure threshold along with that. If you saw really good morphology like that, but you suspected that was the first seizure that you actually had, would you still want to make sure that you increased it to 2 times the seizure threshold next time, or would you be satisfied with that morphology?
We're going to talk about that, but
okay.
I would probably stick with that dose rather than double it up or give it 1.5 times, even though that's what the protocols indicate, right? That you find seizure threshold and then with the next treatment go higher. But usually I stick with this morphology and see what happens. So the other issue that we struggle with is impedance, which is another huge issue for us in psychiatry. Impedance is a combination, just to remind you, of resistance and capacitance. So resistance is the property that quantifies how strongly a material opposes the flow of current. So if you look at these resistances that have been calculated for us, CSF, scalp, and brain are pretty low, but look at the skull, right? 17,000 ohms per cubic centimeter. So the human skull, human bone, does not easily transmit electricity. So the result of that is that only 10 to 20% of that charge that we deliver ever makes it into the brain. And the other issue is this issue of capacitance, which is the property of being able to accumulate charge. And also that is extremely important for us to know, because if we do not do meticulous skin preparation and apply meticulous gels and ensure that we have really good contact of our electrodes on the skull, which is really difficult in some patients with sunken temples or low hairlines. There is a good chance that you get so much impedance there that the tissues simply absorb your electricity rather than let it through into the brain, and you end up with skin burns. And that is something that is not written about, but it has to be talked about amongst ourselves as clinicians. I've created skin burns. It was extremely upsetting for me. A patient went back to the ward with perfect first-degree burns on her temples early on in my practice. A patient with very sunken temples, a tiny South Asian woman with little sunken temples. And there I am with my huge flat metal electrodes, right? So it was impossible to get a really good contact there. Also, probably didn't have adequate gel on the electrodes, and the engineers, biomedical engineers, were wonderful from the hospital and came to help me and had me recreate how it happened. So I just talked about these perfect landmarks that we're expected to make according to guidelines. And it's great if you can. In the end, I teach residents, if your landmarks mean that your electrodes end up being over skull irregularities or sunken temples, to heck with the landmarks and adjust your electrodes as best you can, because the main thing is that you don't see daylight underneath. There cannot be a gap between your electrodes and your skin, because then you get a capacitance and then you get burns. And that is not defendable. If we had to defend one another, we would have to say that it's bad technique. The other issue is this whole issue of electrical current, which is always finding a path, a circuit to go to. So if we are with our hip leaning against the bed, talking while we're delivering electricity, you are actually pulling current away from the patient when we're doing our best to get that little 10% in. So we have everyone off the bed, including the person doing the jaw support and holding the mouth guard in place, just in an effort to try to help the electricity in as best we can. And the rails are down, right, as well, so that if patient's hands flail out, mostly we get gorgeous succinylcholine block, but you can't always predict how it's going to happen. There's a new case report in the Journal of ECT of someone, old osteoporotic lady with a fractured wrist, who slammed her hand against the rail, the exact opposite of what the rail is intended to do. So the hand flails in the air, so then what? Nothing happens. We just grab the hand and put it back on the bed again. So going back to our titration method, there's various protocols available. I've put some of them in your package for your interest. In general, for bifrontal and bilateral, we are increasing by 1.5 times seizure threshold, and for unilateral by 2.5 times 6 to 6 times seizure threshold. This is the protocol that we use. I think it's helpful to have a protocol laminated and hanging on the wall or taped to the machine, so that when you have a whole group of clinicians all giving ECT to the same patient, that you're all using the same protocol and moving up the protocol in a uniform way, rather than everyone cooking up their own doses somewhere in between, because it's, I think, exactly what we're trying to get away from in ECT. So in this protocol, this is pulse width, frequency, duration, and amplitude. Amplitude is held at 0.8 throughout the whole course. And here's the charge that's calculated for us. So, for example, if we were to give ECT in a 20-year-old female, we would expect the lowest seizure threshold. So under that first anesthetic, we would probably set the pulse width at 0.3, the frequency at 20, a 2-second duration. So you get this tiny 20 millicoulomb charge, and hit the button and see what happens, because you have no idea when you walk in there what someone's seizure threshold is. There's no way of measuring it. It's like a shot in the dark. And if you're lucky and that girl has a very low seizure threshold, you'll get a seizure. If you're not lucky, and the way this protocol is designed is that you won't, because it's designed according to a bell curve. very quickly under the same anesthetic and with the permission of the anesthesiologist to ensure that your patient is still soundly asleep and soundly relaxed. Quickly move up the dial to this second setting. So go to 0.3, a frequency of 30, and the duration and amplitude stay the same. So you've increased it basically from 20 to 29 millicoulombs, right? 20 to 30. So it's kind of 1.5 times seizure threshold. Hit the button again, see what happens. Nothing happens, you go to 0.3, 40, 2.5, and 0.8. So you've increased it again from 29 to 48 millicoulombs, 1.5 times seizure threshold. So most protocols, most policies say 4 strikes and you're out under the same anesthetic. It's a huge judgment call. I'm a geriatric psychiatrist. The bulk of my patients are geriatrics. For me, it's 3 strikes and you're out, unless someone's just about dead from depression and you're absolutely desperate to create a seizure. Then maybe if everything is going swimmingly well, we would give 4 stimuli, but I have rarely done that. But the younger adult clinicians who treat younger adults are much more comfortable with giving 4 stimuli. But usually you're able to get a seizure by following that. If you were dealing with a 20-year-old male, I would probably start at level 2. If I was dealing with an 85-year-old male, I would probably start with level 3. He's older, he's male, he's going to have a higher seizure threshold. So, and then move up from there. This is another protocol. This is considered the titrating protocol. So one would move down here until a seizure is established, and then the idea is you move laterally. So if you want to give 1.5 times seizure threshold for bitemporal or bifrontal, you would then, supposing you had a seizure here at 19 millicoulombs, wake the patient up, 2 days later go back in, then you would carry on with this dose and then move down this column for the rest of the treatment. If you wanted to give 2 times seizure threshold, you'd use this column, or 2.5 or 6. The problem with 6 is that you probably end up with high-dose ECT long before the end of your treatment. That's the real criticism of that methodology. That came out of Harold Sackheim's work, who was really so focused on right unilateral ECT as the treatment of choice. And it really also came out before the bifrontal treatments were developed. So it's good to know also there was a time that I think if people delivered a stimulus and hit the button and nothing happened, that they would wake the patient up and send them back to the unit, and 3 days later would go in and try again, right? Now, when we did the Connect data, we asked everyone, what do you do? By far, most people, clinicians across Canada, huge pie, tiny little piece of the pie that was blue. All the rest was orange. Everybody else knows to never waste an anesthetic, and as long as things are safe, to keep stimulating under the same anesthetic until you have a treatment. It means you have to have your protocol right at the ready. I usually cheat and write things out on a piece of paper and have them right ready by the dial, so that the minute we see someone's not seizuring, I can quickly move up the dose and re-stimulate, so that I'm not going to the wall looking for the protocol. Where are we? There's no time for that, right? The anesthetic is so brief. So the EEG is great, but EEG, as we all know, is not a magic bullet, and we have patients who have gorgeous EEGs, and we don't increase the dose because we think we're creating a perfectly adequate seizure, and they do not get better. And we mark that loud and clear on the ECT records for one another, to not let, that's a trap, right? It's a trap because we're trying not to increase the dose, but at the same time, if the morphology isn't linked with improvement, we need to be increasing the dose. So how do we know, what are we looking for in morphology? The adequacy is the gold standard is clinical response, but the EEG morphology certainly helps. So we're looking for very high amplitude waves, the presence of delta waves, polyspike and slow waves, symmetry, so that there's the 2 hemispheres are seizuring in synchronization, and then this beautiful, sudden, sharp, and sustained post-ictal suppression, where you can tell that seizure is finished, no question about it. So the titration method sounds the most logical, and it is not without risk, because in patients who have a high seizure threshold, if you're giving 1, 2, 3 stimuli that are below a seizure threshold, you are not doing nothing, and you are delivering a parasympathetic stimulus. So in patients who have major cardiovascular problem, titration is probably not something that you want to do right off the bat. Anesthesiologists where I work say, we're not into titrating on this patient. Go for the middle of the road on the protocol, and we're going to just hope for the best. Can't have any parasympathetic risk here. In general, we know patients respond faster to bitemporal than right unilateral. Patients who don't respond to right unilateral may then go on to have an excellent recovery with bitemporal. Bitemporal also results in greater cognitive adverse effects, but not nearly so much with these brief pulse devices. But the main part, which I've put in bold here, is that it's the relative stimulus intensity. In other words, the degree that the stimulus is over seizure threshold, that is the predictor of response. So having said that, simply creating a seizure is not good enough, which we know from Sackheim's work. We also now know that seizure length is not a measure of seizure adequacy. And I remember in my early days, we were all striving for 25 seconds. Somehow that was this golden number. I remember phoning Dr. Zist to ask in my early days, what am I supposed to be aiming for? And Dr. Zist said 25 seconds. So we would adjust that 11 o'clock method accordingly. So thank goodness that we're not doing that anymore. So, but having said that, we also know that patients who have ultra brief seizures, 6 or 7 second seizures, can't possibly expect to be recovering from that. And the other thing that's interesting is that in a patient whose seizure threshold is climbing treatment by treatment, and we're not adjusting the dose so that we're becoming closer and closer to seizure threshold, the seizures tend to become longer and longer and longer, and the EEG morphology tends to become crappier. So that's why it's great to have, an EEG record where you can look at the last 5 treatments and watch. No one's increasing the dose. And you can watch seizures going from 27 seconds to 34 seconds to 54 seconds to 1 minute and 40 seconds. And there go the delta waves, and people are kind of fighting about when is there postictal suppression. And that is another indicator. You're getting these long, poorly formed seizures. It's time to increase the dose as well, as long as it is always linked with clinical response. So the missed seizure is always that horrible feeling when you hit the button and nothing happens. These are the things we think about quickly. First of all, if you can't even deliver a stimulus, that there's excessive impedance so that you don't have good skin contact. With the new devices that we have, though, you get a green light, right? You can't even stimulate unless a green light comes on to indicate that is adequate. But also from patients with inadequate ventilation who have hypercarbia and hypoxia, that has a huge role to play in the success of the seizure. So in patients who were really struggling with, always ask our anesthesiologist if they can very deeply bag prior to the stimulus to help actually create something. Where I work at VGH, we have this 90-second policy, and the anesthesiologists set that up, and it's set up out of a kind of a horrible situation in which a patient's intravenous went interstitial in between the anesthetic and the succinylcholine. So they were deeply anesthetized and not relaxed at all. So basically it was an unmodified ECT, had a massive tonic-clonic seizure and fractured T11, T12 as a result. So that was an important lesson to learn as well. Now there was, of course, a whole procedure that came out of that, and there was a decision to really allow at least 90 seconds for circulation of the succinylcholine before the stimulus is given. We clock watch, but we also especially watch fasciculations, toes, The nurses like feeling fasciculations in the calf. I like watching toes because it's most distal to where the succinylcholine is delivered. And we just wait until all the fasciculations have stopped. In the meantime, they're being bagged and bagged and bagged, really deeply bagged. And when the fasciculations have stopped, then the oxygen mask comes off. The mouth guard goes in, right? If you look at APA policy, the wording is the mouth guard regardless of the state of dentition. So it has nothing to do with when there's one tooth or all the teeth or no teeth, because you are still delivering a stimulus over the insertion of the masseter muscle. So no matter what, you get this powerful clenching of the jaw. So when you put the mouth guard in there to protect old osteoporotic gums and palate and do a full jaw support with the mandible to protect that mouth from nothing from happening. So even though you get this, you may have inadequate ventilation. The other big one that impairs a seizure is dehydration. So especially when you have a patient who's just arrived in hospital, who's been sick, who hasn't been eating or drinking adequately, it's worth to even wait for a day to make sure that they're really well hydrated before you start a course of ECT, because you may not get a seizure anyway. And then other things to consider, medications. Benzodiazepines, huge problem in ECT. And also simply insufficient stimulus, that your dose is too low and you need to increase your dose to re-stimulate.
Dr. Gosselin,
if you have...
I'm sorry, but can I ask briefly, just in terms of the hyperventilation, what do you deem adequate? I've seen it done many different ways.
I'm sorry, say it again.
The hyperventilation, what would be a reasonable length of time for that?
Well, as I just mentioned, we hyperventilate as long as we're waiting for the fasciculations to stop. And usually that is a minute and a half. And we have a few old patients with really slow circulation time where it's 2 minutes or longer. We just keep bagging and bagging and bagging till the fasciculations have stopped. For a missed seizure, nothing at all. We can re-stimulate 20 seconds after the higher dose, but it's going to take you that long anyway to adjust your dials and another quick bagging before you go back in. For an aborted seizure, so you get something very brief and everyone's saying, oh, this is way too short, can we re-stimulate quickly, increase the dose? You need to wait 45 seconds to allow for repolarization. Caffeine is a wonderful possibility in patients who consistently have too short seizures. And what it does is prolong seizure time. We are using somewhere between 500 and 2 grams an hour pre-ECT with sips of water. I've experienced the use of flumazenil as life-saving in patients, particularly with NMS, who are on high-dose 3 benzodiazepines who won't seizure, because the flumazenil, right, blocks your benzodiazepine receptors, so it's magic. And it's also given intravenously, and it's the order is that we give the anesthetic, then the muscle blockade, then the flumazenil, then do the bagging. And it has 1.5 or 2 minute half-life. So exactly then we can give the stimulus. The key thing to remember in those patients is to give them a little bit of a benzodiazepine in the recovery period, or they'll go into acute withdrawal in the recovery room. So that's also the work of Andrew Crystal. To monitor seizures, literature talks about the cuff method. I hear from American colleagues that in American hospitals, everyone is cuffed. We don't tend to cuff at all. The peripheral stimulator, there was a question earlier. Also, we rarely use nerve stimulator, but we found it to be particularly helpful in patients, for example, who have just made a suicide attempt and are having ECT with fresh fractures. So rib fractures, humerus fractures, where you want absolutely no tonic-clonic movement whatsoever, then the nerve stimulator will tell you exactly what the point of maximum relaxation is. then it's wonderful to have it there, or patients who are particularly osteoporotic. So a little bit about EEG. So why bother doing an EEG? Also, we've learned this from our Connect data, from your data, from just that ECT course that we give at the CPA for so many years. At the very beginning, early 2000s, we would ask for a show of hands. How many people are doing EEGs routinely every day as part of their ECT? And there would be a smattering of hands. Now we ask everyone's hands go up. So that's a really great thing to see, and great thing that we documented in our publications, that's what's happening here. So, and we do an EEG, number one, to ensure that you actually have a seizure, because sometimes you have such a beautiful anesthetic and blockade that you literally can't see anything, not a toe flickering, not periorbital, nothing. And so then there is your seizure, beautiful seizure on an EEG. Also in some patients who have subconvulsive seizures, right, where you think you have been watching tonic-clonic seizure, you think the seizure is over, but it probably is not, and they're in subconvulsive status. Sometimes the only way you can tell is through the EEG. And for unilateral seizures, supposedly, I've never seen unilateral seizure. Harold Sackheim published not too long ago a clinical case of someone they had who had a unilateral seizure, so I guess it's possible. But I think the other main reason we do an EEG is to make 100% sure that the seizure has ended, right? I always say no one gets to go for coffee until you know that the seizure has ended. And sometimes when you have really poor post-ictal suppression, I alert the nurses in the recovery area and say, I can't tell if this patient is still seizuring or not. Those nurses know exactly what patients look like who are in a post-ictal state. So people are waking up fairly quickly, interactive, right? You can poke them in the sternum and call their name, and they open their eyes or respond. You know that the seizure has ended, and they poke their head around the door and say, everything's okay, they're awake, right? And if not, it's possible you may have to go back in and reattach your EEGs and look to see if there might still be seizuring. The other amazing thing is because I started doing ECT before we had EEGs, and then came the EEGs, then we realized that people seizure for a mean of 10% longer than what the motor component is that you see. We still somehow are in the habit of measuring motor component, but it's quite remarkable. The motor seizure is useless to write that. It doesn't mean anything, that you can really tell what the length of a seizure is on EEG. And so that assists also with our dosing decisions. Very common mistakes is to turn off the EEG paper before the seizure has ended. So people who don't really realize what post-ictal suppression looks like. I don't know what devices you have. We have MICTA where I work. Those EEG rolls is ECG paper, and it's completely cheap. And we just let that paper run until we're 100% sure that the seizure is over. Inadequate skin preparation, so you can get artifact, you get really lousy EEGs. If you use dried up EEG electrodes, so if we have leftover at the end of the morning, we stick them back in the foil packages and fold them up until the next guy. If you leave them laying out there, they'll dry up. You try to do everything right, you have dried up EEG electrodes, you're going to not get a good reading. If you have lousy contact on top of hair, or if you don't have good skin preparation, particularly behind the ear where stuff builds up, sebum. And in the frontal, right, the landmarks for your frontal EEGs are in the mid-pupillary line and then as high up in the hairline as possible. And the reason that they're mid-pupillary line and not touching one another together here is that the closer that the EEGs are, the lower the amplitude on your EEG. And it's coarse enough what we're doing. It's just two EEGs that we're doing. So if you make them further apart, then you get a higher amplitude, and it makes your EEG easier to interpret. So just a few EEGs to show you. This is a dream EEG. This is the, by convention, we have the left hemisphere on top, the right on the bottom. So you kind of get some kindling here at the beginning for the first 6 seconds or so. And then at about 7, 8, 9 seconds, you get these beautiful, gorgeous polyspike and slow wave, the so-called delta waves, also in the literature called regularity. So this whole strip here from 11 seconds to 20 seconds, you have these polyspike and slow waves where each one resembles the other. And then at about 23 seconds, amplitude starts to come down. Your delta waves come back a little bit here, although the morphology is different. And amplitude is much lower. And then very abruptly at 34 seconds, particularly in the right hemisphere, you get this gorgeous strip of flat, sustained postictal suppression. So this is a 34-second ECT or a seizure, which is, if it's linked with good clinical response, an indicator that you're at a beautiful dose over seizure threshold. Mike has taken some of these and laminated them and hung them on the walls, as just kind of a recall of what a really good EEG looks like. It's pattern recognition. Here's a really lousy EEG, someone who's sitting right on seizure threshold. Without a question, it is a seizure. It's very fast, right from the beginning. Amplitude is very low, and it slows down a little bit, 17 seconds. It goes on and on. This is 30 seconds. I've cut some of it out. Finally, at 50 seconds, we do get very nice suppression, particularly in the left hemisphere. We get a bit of a wandering baseline here, but we do get nice suppression. You also pick up, I don't know if you can see this from the back, but you can pick up the pulse, which is obviously the carotid pulse that we're picking up from the mastoid EEG placement. So we should not let that interfere with our thinking that this is good postictal suppression. Here's another interesting EEG, someone with an 8-second seizure, but with gorgeous morphology, right? The two hemispheres are doing the same thing. We have nice big delta waves all the way through, and then this long sustained suppression. So probably in this patient, would be a perfect candidate to give someone a bit of caffeine rather than increasing the dose, right, as we're carrying on with the ECT course. ECT4 is also very interesting because we have these sloping parts to the EEG. There's a lot of blobs of ink. And then at the 13-second mark, suddenly we get a very nice establishment of the seizure, although it's not a great seizure, but we do get very nice suppression at 1 minute and 17. So this is a 77-second seizure. It's quite a long seizure. Anybody know what this is? What are these sloping parts? Can you turn your mic on for me?
Sorry, detachment of the monitoring electrodes?
It's interference. Yeah. Why do you think it might be interference? What's happened? Somebody. I can't hear you, Nirmala. It is. Your electrodes come off, and most likely the electrode that comes off is which electrode? Behind the ear, where it's greasy and warm, and where especially old people have flappy skin. So what we do when we see this, immediately this is a telltale sign someone's electrode has come off. We just quickly with 2 fingers put your hands in behind someone's head and push the electrodes down and just hold them there through the treatment. Right? The stimulus is done, so you don't have to worry about touching the patient, but you recreate that connection, and then there comes your EEG very beautifully. And here's another one. This is an EEG from Wednesday that I quickly turned into a slide. Who knows what's going on here? This is left hemisphere, this is right, this is time. Anybody seen this as well in your suite? I'm sorry? No. Patient had beautiful anesthetic, just quiet as a mouse. This is another form of interference, also where the EEG came off behind the mastoid. And here at the 16 mark is my finger coming down on this electrode, and as soon as you do that, there you get this very nice tracing again, and then get very excellent. You get, actually, this is interesting as well, because you have suppression kind of here between 19 and 20 seconds in the right hemisphere, but not here until 23 seconds on the left hemisphere. So we have to call this seizure 23 seconds, right? Because you call a seizure over when both hemispheres are finished seizuring, not just one. You see that sometimes. And that has to do with symmetry, right? That is a call of symmetry. It's another measure of whether you're high enough over seizure threshold when both your hemispheres stop seizuring at the same time. So, final words on elements of ECT technique. Skin preparation, can't emphasize enough the importance of cleaning skin with alcohol over where all your electrodes are going, EEG and ECT, scrubbing off makeup, hair gel, especially in patients with Parkinson's disease who have this buildup of sebum. Everything you can peel off, you can peel off. And then really good preparation of an abrasive skin gel that you then rub in and then remove, and also the second conducting gel that go completely to the perimeter of your EEG electrodes. I'm aware that some people put a blob and a blob on each electrode and then do this with the two electrodes, which would, I don't think there's engineers in this room. If there is, forgive me, but I think it would make engineers absolutely cringe, because those electrode surfaces are extremely fragile. You have to treat them the way you would treat an LP. They should not be thrown together in a bag where they get scratched with one another. And if, as a group, you start finding that you're having trouble delivering stimuli, sometimes it's purely because the surfaces of the of the electrodes are scratched. And the biomedical engineers take them and polish them. They come back beautifully polished. Boom, you get your stimuli. So we always have a backup pair of polished ones ready to go. The mouth guard I've talked about, and the jaw support I've talked about, and the rails and the footboards. We have some really tall guys we're giving ECT to, and we just yank out the footboard because their toes go down, and you don't want them to slam their feet into the footboards, especially if they're old and osteoporotic. The nerve stimulator is a wonderful tool if you need it. Wonderful pre-oxygenation and optimizing electrode to skin scalp contact. It just really involves biceps. It's not just a polite little touch. It's a really, really firm effort to get as much electricity in as possible. And when and how to stop, my final slide is also our art as clinicians. In general, we begin to see patients beginning to have pockets of recovery. It's very interesting. In some patients, it's immediately after the ECT, right? The nurses tell us someone ate breakfast and went to the piano and had a really good morning, and then by afternoon were horrible again. And other people come back from ECT horrible and dysphoric. And then all of a sudden in the evenings or end of the day have a window where you can see people charting that they're coming out of their room, they're eating, they're more interactive, they're brighter. And then those pockets of time start getting longer and longer. Finally, the only thing that's left is pockets of depression. People are well for the bulk of the day, but they still have a few hours in the morning or a few hours at the end of the day where they're horrible. And so mostly we try to push on with the ECT until they're well day and night. Then we stop. If you can stop, you can stop. In some patients, we can't stop, and we go immediately into continuation ECT. Patients who we know darn well are going to relapse, and we're still adjusting their medications. They're not reestablished, or their doses. It's such a shame to lose the benefit when you have it, and go to once a week for a month and see if they hold, and then every 2 weeks, and then every 3 weeks, and just tease it out. Some people just get better treatment by treatment at the beginning. Some people boy, treatment 12 and 14, everyone's looking at you, wondering, what are you doing? You know, this guy's not getting better. And then all of a sudden, in one treatment, if you persist, there will come the recovery. Then you need 3 more treatments and they're done. It's tough and it's wonderful. I'm going to stop. Thank you very much. Good luck.
Thank you very much. Thank you, Your Majesty. So, personally, I think flappy skin is a contraindication to ECT. We're going to take a 15-minute break, and we'll start again at 1:15, and then we're in the home stretch. Refreshments outside. Maybe not. I don't know.
Well, so far I've been getting a lot of positive feedback from everyone. So,
I mean, directly with the policy.
oh, with the policy, right?
Yeah.
Yeah. Let's see.
So we need to know sound, lights, audience, audio sources.
There we go.
And then these are the handhelds, right?
Uh-huh.
You're number one?
Hello? No, wireless.
Oh.
Hello? You muted. You muted me.
Well, but we can do it. Hello?
Hello? Hello? Hello? Okay.
I tend to speak quieter. Oops.
I
Okay, we'll get started. Dr. Gosselin's got groupies.
Mm-hmm.
Okay, home stretch. So the idea of today was to have a review of all those topics we've had today, and thank you for all the presenters, and then some of the updates, and then take all that information and combine it with your experiences, both in Fraser and other places you've worked in your careers, and start hammering out a policy. Now, none of the health authorities have a policy around ECT, and so we were asked as the ECT working group, Heather and I, to start looking into drafting something. Now, a few weeks ago, we sent out something for everyone to take a look at. Thank you for all those that have responded by email. But we knew that today we've captured the audience a little bit to get some more feedback face to face, especially after a review of the salient topics today. What I asked you to do, they're included in your package, so you can take them out, the draft, the most recent draft, and it's a working document. So in a way, this isn't a presentation as much as we're kind of part workshop, really. So to start out, does anyone know what all these celebrities have in common? Julie Goodyear, anyone a Coronation Street fan? I'm not, my wife is. I'm more of a Walking Dead fan. American writer Ernest Hemingway, guitarist, songwriter Lou Reed, rest in peace. Connie Francis, singer, Cole Porter, French designer Yves Saint Laurent, and Carrie Fisher, Princess Leia, and my first love. Anyone know what they have in common? They all had ECT. So I'd like to thank Heather, who not only pulled together the initial drafts of this policy for ECT for Fraser, but also postponed her vacation to attend this day and organize so much of it. So thank you.
You're welcome.
So the objective of the next 45 minutes, 50 minutes or so is to review and develop some documents, particularly really just one. Initially, we were a bit ambitious. I was a bit ambitious, thinking we can get into protocols and procedures as well. But we're just going to look at the policy and some of the challenges I'm having with it. But we want to first sort of just address and get out of the way that the big issue really in Fraser, I think, also is capacity. This is the landscape as it stands. We have, 12 hospital sites, 10 of which do ECT. So there's no ECT at Eagle Ridge and at Fraser Canyon Hospital, and none at Mission Memorial. And we have the New West Surgical Clinic doing the most, actually, 12 ECTs a week. So, of course, the challenge is the geography, first and foremost, I think. And so part of this policy, as we're looking at it regionally, is how are we going to capitalize on what we do have, and in terms of accessibility. But in that also is quality, ongoing quality improvement, and trying to maintain some high standards and defining what that means. And I've shown a slide at a physicians meeting a few months ago if you were there, but some of this information. So in Fraser, we have a total across those sites, including New West Surgical Center, of 74 ECT treatments per week for a population of 1.7 million people. I just want to contrast that to Vancouver Coastal, where we have 112, so about 40 more treatments per week, but for a population of 500,000 less. So I don't know why, but really I think it may speak to the fact that we actually could use more in Fraser, and we need to advocate for more. But in the meantime, still look at how we can maximize what we do have.
Okay, so this is a graph that is compiled from a weekly report that I create. I'm not sure if any of you have seen it. I create a weekly utilization report. So each week I look at how many ECTs were done at all the sites. I look at how many were inpatient, how many were outpatient, and then we look at how many ECTs were scheduled and how many ECTs were actually done. So the blue bars are what was intended for each site, and the red bars are the ECTs that were actually administered. And you'll see that a lot of the sites are at about 80%. Ridge Meadows is very close to 100%. And Delta, unfortunately, we only have the one psychiatrist there, and so we're only doing ECTs every other week. And so we're not able to utilize its capacity. Yes? Yes, so I look at any cancellations. So if there's cancellations because either the patient's sick or they didn't show up or because the OR slate bumped it, there wasn't an anesthetist or there wasn't a psychiatrist, any of those cancellations would be reflected in that. This is actually the current year, so this is the fiscal year for 2014 to 2015. So this is as of last week for the whole year. So I think we can move on. Yeah.
Okay. So we were initially asked to do policy and procedure for ECT, and in my experience, every time people talk about policy and procedure, I kind of nod off a little bit, thinking it's a little boring and useless, but I no longer think it's useless. I think it's still a little dull sometimes, but it is very important that we look at what that means. So traditionally, policy and procedure is put together. What Fraser seems to have done is separate policies, clinical procedures, protocols, and practice guidelines. And so I just wanted to give just a brief explanation of some of that. But it is on the intranet. And what I'm going to ask, what we tried to do in this draft, and what I ask of you is try and separate in your mind what policies should be in place, and there are policies that apply to all of Fraser, not site-specific. Things that we can say, no matter where a patient's going to go, if they get outsourced to get their treatments, they can depend that it's going to be done the same way. Okay, so that's what our challenge is. What did I do? Thank you. So this is actually on the intranet now. We'll go through the policy description in the next slide, but the idea of what a protocol, procedure, and a practice guideline is what I wanted to touch on. Now, the clinical practice guidelines are systematically developed statements to assist practitioners and patients, clients, to make decisions about appropriate health care in specific clinical circumstances. And they're supposed to be flexible, and allow for intervention and treatment options with expected outcomes and evaluation strategies. So these are consensus statements, established guidelines. So what we did was we turned to the CPA ECT statement. In 2010, we turned to the APA guidelines, as you've heard of, 2001. There's also the college report from the UK. And that's 2013, you've heard about earlier this morning as well. And there are other resources that we've used and we've referenced in the draft so far. One's the Mancad one, and another one I actually haven't put into the references is Abrams, just because it's before 2000. I think we can stick with everything after the year 2000. What I'm trying to do is avoid just repeating all of that in a policy. Because some of that can change depending on the change in evidence for the clinical decisions. Now, I'll skip to the brown line. The procedures, they're basically designated, procedures are designated processes describing the method or the steps required to complete a clinical technique or psychomotor skill. So they're very detailed sequential instructions and very professional or discipline specific. So this may be where maybe how we describe doing the ECT rather than a policy. And finally, the protocols are a set of specific rules or required actions which explicitly direct assessment or management of a clinical condition or a population occurrence. And I'll give you some examples of those as well that we'll probably be also asking well, ourselves, maybe you to help us write for ECT. So the clinical policy criteria, as written in the Fraser Health Authority intranet, are described as formal and authoritative statements that express our values, our intent, and expectations of the organization. So they're broad statements. They deal with recurrent issues and ongoing situations rather than one-time events. So, for example, a protocol that I'm trying to work on is a protocol for ECT where a prolonged seizure occurs, which is more of a one-time unusual event. A policy would be something wider and recurrent. It's organizational-wide in implication and allows for flexibility in implementation, enabling the broad intent of the policy to be applied to various situations and sites. It's not subject to frequent change. It can apply to both clinical and non-clinical issues. It establishes realistic standards and expectations rather than setting impossible or unreachable objectives. So whatever we put into this policy is not just an expectation of you as a clinician to meet, it's also the organizations to set the circumstances up where we can meet them. Okay, so it should be realistic and sustainable and not impinge on our patient care, but improve upon it. It provides broad direction by describing values, intent, and expectations of an organization rather than dealing with operational details. So we leave those operational details and how-to details in a procedural document, which we can talk about if we need to do those. And we use the active voice in the present tense whenever possible. Does that make sense? I'm trying to wrap my head around it as we're going along, actually, because it sort of blends into practice guidelines in my mind and procedures. Now, I mentioned a few of the references that are in the draft so far. If you have any more that you think would be useful, please let us know. Now, those drafts are not for you to take home because we're depending on you to write in your comments, and we're going to pick them up at the end, and then we're going to tabulate all of them, and then fortify the draft that you're currently holding with your comments. Okay. But the other reference that I want to turn your attention to is one that just came out last month. Is the ECT standards. And Peter Chan mentioned this in his talk, but he referenced a 2013 one. There's actually a new one from last month. And that's not included in your package, but it's easily downloadable for free online. I really like this one. It's a little bit, it can be a little bit hard to obtain, but it spells out some of the standards that ECT clinics in the UK are expected. Many of you are probably aware of it. I'm just learning about it. But I like the fact that there's every standard is assigned a 1, 2, or 3. And where did I put it? So that for standards that have a type 1, criteria are described as failure to meet those standards would result in a significant threat to patient safety, rights, or dignity, and or would breach the law. So those are absolutes. So we're going to target all the ones as something that need to be looked at for all the sites in Fraser. Type 2 are standards that an accredited clinic would be expected to meet. And type 3 are the standards that an excellent clinic should meet. And I think they say even in their introduction, very few would actually meet all three, the threes. But we're going to at least aim for the 1s and 2s, maybe in the next couple of years that we do this work. But please, if you have some time, it's a reader-friendly, a very thorough document, just point form. Also in the back are protocols, and this is something that, I would welcome any assistance in writing. But they have 21 protocols that they think ECT clinics should have, 7 of which are rated as 1s. So policies relating to ECT are reviewed at least once every 2 years. So what we're writing today together will be reviewed in the next couple of years again. The next one is how and where the initial and subsequent doses of dantrolene are stored. I think I'm going to need some help with that from anesthesiology. And then a protocol for management of cardiac arrest, anaphylaxis, malignant hyperthermia. Some of those will not be under psychiatry, of course, but we should have those at the ready at the clinical, at the ECT suites. And And then there's a number of other ones that are listed. Even a protocol on the use of EEG monitoring, and that's assigned to 2. And management of prolonged tardive seizures, and a local protocol about the quality and timing of an adequate seizure, as well as titration. So those are things that we can look at in the next little while as far as protocols are concerned. So what we'll do is now just walk through the policy draft as it stands and listen to your comments, and then we go home. Word document. So if you follow along, the policy so far is, there's a template for it, which we're trying to put in information. So it starts out with the policy, the purpose of the policy, which is to start, what I wrote anyways with Heather is to establish a standardized approach to the administration and delivery of accessible, safe, and effective ECT services within Fraser Health Authority. If anyone has any comments or additions, please speak up now or write them onto the draft in front of you. Sure. No way. Okay. Can everyone? Did everyone hear that? Okay. Well, I think that's what I struggle with as well, is across the sites with different resourcing, perhaps. These might be better described as guidelines. I think the idea of the policies are that it doesn't matter which site you're at. Again, it should be standards that are achieved, and if they're not, because of resource, whether human resource or equipment, then we have to look at that seriously and upgrade. But it's meant to be something applicable to all sites. But let's go through it and see what it is because I don't think, going through this, what I've seen so far with what we've written, I don't think any site's particularly lacking. But again, I don't work at every site, but let me know if you have any concerns. They want us to describe the scope of the policy, so what we can and can't really do under this policy. So what we've written so far is this regional policy applies to all FHA sites providing outpatient and or inpatient ECT services. This policy aims to provide uniform expectations with respect to organizing, prescribing, and monitoring ECT courses. Individual sites may have specific and local implementation requirements and may require separate documents outlining procedures. This policy is not meant to rewrite established and accepted DCT practice guidelines, standards, and position papers, in particular those of the Royal College of Psychiatrists in the UK, the American Psychiatric Association, the Canadian Psychiatric Association, and the guidelines for health authorities in British Columbia. That's the BC guidelines from MECU from 2002. But instead align with their recommendations while instituting local practice. So again, with that statement, we're trying to separate out practice guidelines that maybe talk about whether we should be using bifronto as the default stimulus electrode placement for the beginning of an ECT course. That would be better a practice guideline, which may change as evidence and scientific literature builds up. John?
Michael, it would help me a little bit if I could have a little bit more of the context of this. I mean, obviously, we want to have people that are doing ECT well educated in the service and using best practices. But has there been some problem with that approach that now requires a formal policy? Because in terms of general, medical practice, we're all needing to, keep up our skills up and whatnot, but we don't have policies in
Right.
place for everything we do. So can I have some context for this a little bit?
Actually,
Perhaps?
that's a good question, because one thing I want to say as well was we took all those above mentioned guidelines, position papers. We also took into account the critical incident quality review from last summer at Memorial. So I took those recommendations as well. They were in my back of my mind when we were writing some of this as well. I'm not sure if there's any other reasons that this came about other than we don't have one, and other health authorities are looking into writing one as well. And I think maybe it's just because Heather and I are around now to do something like this.
Mhm.
I don't think, other than that, I'm not sure of any other impetus.
I think there's also been a bit of a regional push to have established policy as well. So, yes.
Do you think actually it would be more legitimate to get a sort of anesthetist on the board as well, just to actually have some standardized doses of various anesthetics? Because, this is good enough for the psychiatric team, the nurses, and everyone, assuming that actually patient is going to have a good seizure. So you have to realize that you're not in control in that ER. So then I think you have a partner, and you got to establish some guidelines with your partner as to what dose of medication needs to be chosen, because there's a sort of wide range of dose that has been chosen according to each person's, whims or whatever. So I think in a way it would be nice to actually stimulate our colleagues actually to some of the scientific papers where some of the established guidelines have been used, and established studies actually have shown that some of the doses are pretty safe and will give more fidelity for the ECT procedure.
Okay, I'm sorry. And was there a question in that?
No, I mean, actually, just wondered actually whether it would be appropriate to invite the anesthetist colleagues.
Oh, I see. Okay.
Yeah.
Actually, there was a question of anesthesiology and whether we need to. Oh, right. So some of the email comments, I remember now, is can we have some standardization and uniformity around the anesthesiologist's approach to their medications as well? And that would be, I think, part of the future discussions with our anesthesiology colleagues. So the head is Dr. Blair, and I think it's in all the health authorities. There's sometimes it's we haven't collaborated well enough with anesthesiology, and we have this at VGH as well. We're trying to have journal clubs that involve all the specialists, and so we can come to some sort of understanding. Because the sites that I've worked, the ones that worked best with anesthesiology were the ones where they actually dedicated one anesthesiologist to all ECT, and they not just only get it to know our practice, but they also know our patients. So it's just, I think it's just human nature to, if you have a rotating anesthesiologist schedule, it's not as easy to have some uniformity. And I was thinking about that when Dr. Johnson was talking about, there were some questions around, well, one anesthesiologist might have a difference in opinion from the next one. Even at VGH, we'll have someone that does anesthesiology for a patient, thinks that they're ASA4, they shouldn't be done in the ECT suite, we have to do them in the PAR. We send them to the PAR, which is a lot of work. And then the next anesthesiologist says, well, why are they here? So I think I've come to appreciate there's a lot of variability in their practice as well. And so I think the best we can do is start talking to our anesthesiology colleagues. So we'll take that into consideration.
I know there was a case, someone I had referred for New West Surgical Center, and they only do ASA 1 and 2. And the anesthetic consult put this person as a 3, but their medical history didn't indicate why they would be a 3. So I had Dr. Johnson review it, and she spoke to the anesthetist, and apparently that anesthetist automatically classified anyone who was a psych case as an ASA3, regardless of what their medical conditions were. So that's where we have to do some teaching.
I'll let you take over for policy.
Okay. Oh, we're going to do the
Definitions first.
definitions first. We thought we'd go through the definitions part of the policy first, just so as we go through the rest of the policy, you have an idea of what the terms mean that we're going through.
Sorry, I'm fiddling.
No worries.
Go ahead.
Okay. So we've defined electroconvulsive therapy as a biological psychiatric treatment modality used for alleviation of symptoms arising from mood or psychiatric disorders. Contemporary ECT includes inducing a therapeutic seizure under controlled circumstances and under a general anesthetic. And we've defined the ECT practitioner as a psychiatrist who is trained and privileged in delivering ECT treatments. The psychiatrist may review for updated consent documentation and the patient's clinical status for the day of this treatment session. Yes. So what we're thinking in this application would be someone thinks someone needs ECT and they want a second consult, so they're approaching the practitioner ECT. Yeah, they can. Okay. We're also talking about just checking in with the patient briefly before their ECT. How are you doing? How are you feeling? Have you had any issues? Okay.
So what's the question? So I'm taking notes as you're speaking, so I missed it.
Mm-hmm.
No. And that's what we're trying to do with this. We're trying to separate out and clarify circumscribed role and responsibility with the ECT practitioner, supervisor, and consultant. So again, we can use your feedback on this, but because there is a blurring, and I think we have to accept this overlap. But the ECT practitioner really, it's not push button psychiatry. It's not we're not just technicians, but that there is an aspect of the practitioner being right. But as Dr. Gosselin said, I think we can't. The buck has to stop with the practitioner if there's something amiss, if there's either consent issues or a change in medical status. The practitioner is not just a technician that does whatever is ordered. So there is a certain amount of clinical judgment, but it is the day of treatment. And there are certain things that we have to, certain times we have to assess, where a patient has an acute change in clinical status. But for the most part, the ECT practitioner would be, and that's everyone in this room at this point, versed and comfortable with assessing and commenting on electrode placement, pulse widths, and titration versus half-age placement. Those sort of come under the practitioner's view, because I think practitioner's recommendations, and then it becomes a collaboration and ongoing discussion dialogue with the other ECT practitioner clinicians in terms of the supervisor, which could be the inpatient psychiatrist or the or an outpatient community mental health team psychiatrist, but someone that oversees the overall psychiatric management, including the medications and the interactions between the medications and ECT. And we're trying to separate that from the ECT consultant. And what I'd like to see is, if you have, I think it's not problematic from what I've heard so far, getting a second opinion for ECT, but an ECT second opinion service that's much more robust, and that's all of you as ECT practitioners to go in and make to do a second opinion and start discussing what maybe is the best way to approach ECT. A second opinion around consent, because they can be quite tricky and thorny issues, and start guiding the ECT supervisor and the rest of the psychiatric team on how to include ECT as part of their treatment regimen. So yes, those three roles overlap, but yes.
Yes.
In fact, I think one person can be all three at any given point, right? Now, I think what I've heard for some of you, some of the smaller sites it's not easy to get a second opinion, and perhaps even or worry that there's only 3 or 4 psychiatrists, and there's you would like more arm's length. So maybe someone close by in another site that comes in and does that, and vice versa. Maybe that, and if people are interested in that, please put that down, and we'll make that a priority if enough people think that's something you want. Okay, nurse coordinator?
Sorry?
That's you?
All right, so the ECT nurse coordinator, which is, that was too much, which is my position, provides clinical support and leadership for the ECT program and provides the scheduling of patient assessments and their ECT treatments in concert with other ECT nurses in the region. So I'm the one who looks after the outpatient referrals usually, and make sure we get the anesthetic consults and all that kind of stuff done. And then we have our ECT nurses, and there's only 4 of them currently in Fraser Health. We have one at Ridge Meadows, Surrey Memorial Hospital, Burnaby Hospital, and RCH. And the ECT nurse ensures the booking for ECT treatments at their sites and the anesthetic consults. They complete the clinical assessment of the patient's pre and post treatment, and this person may assist during the ECT procedure and ensures clinical documentation is completed. So. Are you doing this part?
Okay. Yeah, we're really prepared. Okay, so under the policy now, so we just grouped them together based on the template that was provided and what seemed to flow. So we put together consultations and assessments. Just take a look at 7 points. So I hope this is all in keeping with what's being discussed throughout the day, but we wanted to start clarifying how we approach assessing someone when we think they're ready for ECT or requires ECT or would benefit from ECT. So we want a written psychiatric opinion, and it must be obtained to determine the need for ECT, including a diagnosis, history, mental status examination, and rationale for ECT, including target symptoms. So that's pretty standard. What we didn't add was and we may give some consideration to, is whether we want to say you have to have some sort of scale, whether a self-report or clinician-rated scale. Is it just for mood, psychosis, or do we also want a documented MMSC or WOCA for cognitive screen? I think that's fairly standard anyways, because we want to make sure we want to pick up any cognitive impairment. But do we write that into the policy? It is one of the, I think, ECTAS expectations. So again, if there's any thoughts around that, let us know. Do we specify which ones we want? At VGH, we have like half a dozen, it seems like, depression scales. But we leave it to the practitioner, ECT supervisor to choose which one they want, which one they're comfortable with. But usually we use Beck, the Maters, or the HAMD. Yes. So you're saying that for involuntary patients, involuntary, you don't need a second opinion. Okay, I think our practice I'm used to is anyone involuntary and certainly incapable requires second opinion. Okay, so we can delineate it. Okay. So anyone incapable gets a second opinion. Someone that's involuntary incapable does not need a second opinion. Splitting hairs. Okay.
So I think we need to reword that then to reflect that an involuntary patient who is incapable of providing consent. Right. I believe it is required.
If they're incapable,
If they're
there's a must for
incapable.
a second opinion.
Right. So we'll just change the wording of that section to reflect that then. Okay. Yes.
Just to follow up on that point, maybe it could be specified that anybody who has been deemed incapable of consenting on the Form 5, maybe reference the Form 5 in the policy somewhere.
Oh yeah, later on.
Might be helpful.
Oh yeah.
Right.
But the problem is, if there, as John Wu was saying, if there's an inconsistency between the Form 5 and your assessment of competency to consent, you're setting up a potential problem. If this is a legal document. Yeah, but that's not my point. My point is that it's inconceivable that somebody is incapable of consenting to treatment on a Form 5, but then is capable of consenting to treatment for ECT. No, Form 5 is consent. Yeah. There's two sides on the Form 5. One is where the patient consents, and one is where we consent for the patient. Okay. Well, probably that's enough time on the point, but it just seems a setup for some inconsistency if we're declaring somebody incapable of consenting on a Form 5, and then we allow them to consent for ECT at the same time.
Right.
He came in, for instance, and you'd done the Form 5 because at that general point, the immediate decision was you need to be in hospital, and then something happened subsequently, and the decision then was we need to move to ECT. And it may well be that the clinical circumstances had changed, so that at that point you thought this person has the capacity to consent, but you have raised a conundrum in that you are saying at some point there was a decision made to suggest that there was an impairment of capacity. And I would think, I don't know, perhaps just a suggestion, a reminder somewhere that, look, if you have a discrepancy somewhere, it might be a flag for the clinician to think.
These are great points because we struggled with this too. And there's well, we could just go right to it in a section of consent. And it's pretty short, 3 points, but we were struggling to figure out how to word that too. So yeah, because the common clinical situations, they come in, we think they'll get better if we just bump up the bupropion or whatever. But then a week later, nothing's budged, there's not eating. And think, you know what, we got to do ECT. But that's not on the initial Form 5, which is already signed off. So the question is, do we do another Form 5, a second one, and scrap the first one, cross it out, or is it in addition? And this morning, Heather Doyle was talking about, well, at VGH, what we do is a procedural consent. I wasn't keen on it at first when I worked there, but I like it because it actually includes everything else that, like the anesthetic risks, and also it includes things like you may have medical students and residents as part of the treatment team. The Form 5 under the Mental Health Act doesn't have that, so it fleshes it out a little bit more. So I like that. But so it's but that's up for discussion. Do we do a second Form 5 that now includes electroconvulsive therapy in addition to, and how do we track that it's been done? Is that enough? And is that with or without another procedural consent that we use for surgery or medical procedures? Is that sort of getting closer to what you're bringing up? Yeah. And so again, we haven't decided. And I think, as per Dr. Doyle's talk, there's no litigation that would guide us there. But what would we feel comfortable with in this health authority? And that's where your comments would be. Will fall. We'll take your lead on that. I think a second Form 5 makes sense. But if we could jump to the consent piece, basically the highlighted part is the part that we're waiting for risk management. I called them a few weeks ago to see if there's anything that they would recommend. They didn't have anything offhand, but they're looking into it. But I think we can just say we use our regional consent. And that's one of the references in this document, is that we could just go that direction and say, if you want to add ECT onto the treatment regimen as an inpatient or outpatient, we can do that consent and that will cover it. So you're saying it's ECT specific consent? That's the that tact. We took that tact at MSJ because the APA as one of their appendices in that 2001 text they have actually has a whole letter that outlines for the patient the procedure and the risk benefit and the potential adverse outcome, and then that's their consent. I like that one. Yeah, and I think if that's where the group wants to go, we can talk about just devising a separate ECT consent, separate from the surgical. Yeah. Okay. Jenny?
I'm in favor of that. I think it's very frustrating when the consent forms look really different. When a patient's coming into a procedure and I'm looking for the consent form, and it may be a Form 5 and it may be a procedural consent, and it may
Yeah.
have up to 15 treatments on it, or it may have up to 6 months or whatever. There's a lot of variation. So it's nice to have like a standard consent form with the information attached so the patient knows what they're getting into.
That's recognizable by all of us. Well, and yeah, that's the other issue. Do we have a separate one for maintenance or an index, or outpatient and inpatient? That'll be another. I'd like your feedback on that too. So is there any other comments or support for that?
See, I agree with the Nirmal's suggestion. That's very practical and probably very thorough.
Okay. So, Nirmal, do you want to draw one up? Karen? One thing we don't have in this policy yet, which we should, is how often the consents need to be, how often the capability has to be assessed, and how often, and separately, how often the consent needs to be signed. Would that address some of that concern? Mm-hmm. True. Sure. I think that's great. So it will be the ECT supervisor, whether it's an inpatient, MRP. As opposed to the ECT practitioner or consultant. Yes.
Yeah. The other check and balance we have in that is that we're going to be doing a standardized pre-ECT nursing checklist, and part of that checklist will be to verify that consent is valid. Yes.
This is a slightly different topic, but I still on the consent topic.
Okay.
In my dream world, we would have one of the items on the consent be that the patient's data could be used for research purposes. I know that that's kind of a, outside of the scope of this discussion today, but if it could be as part of the package, not that the patient's name would be used or that, it would be sort of chart data. As a group, we would have a lot of information we could use for research.
Actually, I'm not sure if it's not outside the scope. I think it's. Quality improvement.
Mm-hmm.
No, would that cover what you're? Yeah. Yeah, I think so too. And actually, I don't think that would be too difficult to do.
Okay.
We are, as an FYI, UBC's doing ECT-COM. It's going to be at the point of referral to ECT, they're going to take a number of information, demographics, and indications, and they've just started rolling it out in the last few weeks on their inpatient units at UBC Hospital. And then once this pilot is over, I think Fraser will be interested in being part of that. And it's a start in trying to start tracking quality improvement. But it will be supported. I think it's all web based, and so I think if we're going to do that, it might be worthwhile to put that into the consent. Absolutely. Thank you for that, Jenny.
Okay. So to move forward with the consult part, so we're saying, and this is supported by MECU, a second written opinion by an ECT practitioner is required for a patient that has not responded to 15 treatments when continuation is indicated. The next point is anesthesiology consults to be completed within 10 days for inpatient index courses and 30 days for outpatient treatments. The next point we've got is medical.
Sorry, so shouldn't that be that consent piece? I think Dr. Kang, you were saying that would be the MRP, is that right, or the supervisor rather than the person administering the ECT that's responsible for getting consent
for inpatients
after 15 treatments or whatever the
Yes. So we're talking about the second. Are you talking about the point 3?
Okay, so for the second opinion. Okay, so the initial one will be done by the MRP.
It should be MRP, but we've noticed though, VGH, when we do second opinions, that it's actually much more convenient for the person doing the second opinion, the ECT consultant, to just write the first week of ECT at the start, because they're the ones contacting the ECT nurse to book it and say it's okay to go ahead, and rather than waste time, wait the weekend and then the MRP comes back and then review it. So we could put into this process that the ECT consultant orders the first week's worth of ECT and index ECT, but I don't know if that's onerous. Is that doable? Feedback, comments? Right, because if you don't want to write something and say the ECT consultant starts the ECT course by writing the orders, and then do they do it or do they not? And then the MRB. But I'm just saying that what we find is that at VGH, then there could be a lag time between that second opinion and actually the order. Other inpatients. Yeah. Okay.
Mm-hmm.
Okay. That's applicable to other sites as well?
Mm-hmm.
Yes. Which site do you work at? Which site is that? Abbotsford. Okay. Right.
Right. So point 3 is in relation to an index course. Yeah. That's- Yeah. Yeah. Okay, so point 3 is basically out of MECU, and MECU has not specified how they're measuring no response. I would imagine that we're going to be monitoring that through scales and just, looking at the patient's progress
I
since
mean,
starting the course.
we could specify what response is rather than remission, or we could say we need to have scales and show a 50% reduction, 40% reduction. But do we want to go there? I take your lead.
Yes.
My personal opinion is that we shouldn't use scales that way. Sometimes the scales and the clinical impression of the MRP psychiatrist can be quite divergent. And in that situation, we may be not doing the patient a service by putting too much importance on the scales.
You agree?
We're not expecting the practitioner to do it.
Oh, no, not the practitioner, but the staff, the inpatient, MRP,
Mhm.
mental health team.
And in the case of an outpatient, it could be the case manager from the mental health team. It could be the outpatient psychiatrist or private psychiatrist.
I mean, things are moving towards more scales based and some sort of objective rating. Do we want to incorporate it early on, adopt it early, or do you want to let the definition of response be very subjective right at this point? Well, yeah. When what we've been doing at VGH anyways is second opinion doesn't mean a full out. It just means another psychiatrists saying, I think it's worth continuing on. We've thought about it. I think the objective is to avoid just going on indefinitely without some sort of reassessment, just like for maintenance. So we pick a number where we will look at it again. That's all it really means. It's not meant to be a barrier, but it is meant to just protect us and say we're still watching and monitoring. So.
Okay, so 0.5.
Actually, 0.4. We all agree. I don't want to assume, but we all agree that everyone needs an anesthesiology consult, right? Because I didn't get the sense when I was listening to Dr. Johnson that when she was talking about internal medicine, it almost sounded like sometimes they don't really come in without anesthesiology consults. I know there was a time when we didn't, if they were healthy young people, we didn't do anesthesiology consults on everyone, but now it's considered an expectation. That's where we're at, right? Okay. I just don't want to assume. Okay, number 5.
All right, so 0.5, medical investigation, which would include but not limited to a CBC, electrolytes, an EKG, and those must be completed and reviewed by the anesthetist. And then supervising psychiatrist and ECT practitioner prior to the first ECT treatment. And then 6, we're discussing other consults, so dentistry, cardiology, neurology, obstetrics, geriatric. Yes. So, okay. I know that might vary by site, and I think it doesn't matter necessarily who's ordering it as long as they are done before the ECT. I know when I arrange anesthetic consults for outpatients, I'm making sure that the lights and CBC and the EKG are done the day they're having the anesthetic consult. They go in just prior, like a half an hour earlier, and the results are usually there for the anesthetist to review by the time their consults due. So the other consults, 0.6, this is more just as the need would arise. So it's clinically indicated by the patient's medical condition. Patients with pacemakers must have a cardiology consult for risk assessment prior to commencing an ECT course. Older adult patients who have medical conditions comprising their physical status and resulting in frailty should have geriatric medicine consultation prior to commencing ECT.
I think you should add what you just said. This is more depending on as the need may arise.
Must be consulted as indicated by the patient's medical conditions.
I like to have each other back in one of your medicine concept. I don't know how quickly you get to it. You may get medical concept, but not very medicine. We are in Berkeley, we are very medicine, we try to hospital very medicine concept.
Okay.
So it's easy to put it in the name, or as for the need, but it's quite a discretion. But if you don't put it all the way to no medicine done, it's easy to cover. It would be nice to get very medicine. You don't need to go for medicine.
And one of the objectives is protect us. So if you think we need to say a must, then the onus is on us to may not must. Means that must. Okay. Okay. Because if they must, we have to make sure it's available. The organization. So may is better.
Can you use the mic, please?
How do we get dentistry if people can't afford dentistry consults?
If they have loose teeth, we shouldn't do ECT until they get a dental consult. So,
again, Mike, that's something we encounter every day, and we treat people with ECT who have loose teeth, missing teeth, one tooth. I think hopefully this policy isn't going to hand tie us in terms of providing treatments for our patients in a timely fashion. I think when we have words in there like dentistry, cardiology, geriatric medicine must be consulted, I think it just adds another layer of complexity in terms of getting them timely treatment.
I used to think these policies are too top heavy, top down, right? But I think again, I come to appreciate that this also protects us, because if it's a must, they'll say, if it's important enough, then the onus is then back on the organization to provide it or make it easier to have access to ECT. So, but if it's not available, then we have to figure out something. Because in the States, the successful litigation around ECT is around aspiration of teeth, loose teeth. It's not around really cardiovascular complications. We can make sure that the anesthesiologist does this. Oh. I'm flabbergasted. Okay.
Yeah, so I think you need to leave some wriggle room.
Yeah.
In the
and the anesthesiologist colleagues are also, there's checks and balances. Money master. But I mean, I don't mean to be flip. I mean, safety is, of course, we'll lose our credibility of this treatment modality if we're too loose on it, right?
Yeah, I think this flags that you should do these things where there's a significant risk, and if you're choosing not to, say because it's more important that the person gets treatment for ECT, it's a bigger risk that they get, that treatment goes undone. That that's recorded in the notes as to why you've made that decision. It just allows you to have still some clinical discretion, I think.
So we'll need to word that.
I think,
as indicated.
Room for clinical judgment. I think it's worded fine.
I would change must to may.
To may.
Must does sound a bit, if you haven't done
Right.
it, the assumption is that you've...
And I wrote must just to stimulate discussion mostly, but and it worked. Okay, may. And I have to admit, I have this quality review sitting on my desk that seems to weigh heavy on. I don't want to. I know there's that's something to keep in mind. That we keep really high standards. Okay.
So the next and last point in that section is that we want a pre-ECT nursing checklist to be completed prior to each ECT treatment section. And any abnormalities communicated to the ECT practitioner or anesthesiologist delivering ECT that section. Right. Which two are you referring? Okay.
Would you believe there were more than these forms before? We've actually cut maybe 50% out already.
The ideal actually with this outpatient maintenance ECT form is that this is what the supervising psychiatrist in the community would be filling out with a progress note and sending in for you guys to review.
Oh, this one. If you write that down into your recommendations, because we're trying to, we try to consolidate as many forms as we can, but then there's also different situations from different sites. Some people don't have outpatient services, and then there's the mental health teams we haven't quite consulted with yet, and we're going to do that a little later on. But what's the best way to communicate?
I'm sorry, I can't hear you. Uh-huh.
Oh, this is for the ECT supervisor. Maybe that's one thing we can relabel this one. This is not for the. This is for the ECT supervisor if there's an outpatient clinic. Yeah. Let's look at that.
Okay.
I'm trying to save you from forms as well as. Can you give me the other one that he's referring to? Can you give me the other one that he's referring to so I can just make a note?
I'm not sure what the other form is that he's.
Okay, give me that one. Keep going to policy.
Okay. Okay. So for ECT prescribing, we've said that there must be written orders for the ECT before proceeding by the supervising psychiatrist or designate. The orders must specify the number of treatments requested for index or maintenance ECT. The orders must specify the frequency for maintenance ECT. And the orders must specify which pre-ECT medications should be given, withheld, or adjusted. There must also be an order to maintain NPO status 8 hours prior to treatment. And the orders may include placement of stimulus electrodes. Part 2, the order for an index ECT course, if it does not specify the number, is applicable for up to 15 treatment sessions, and that's in line with MECU. Another order must be written if further treatment sessions are pursued after a second documented opinion supporting this is done. The second order is also applicable up to another 15 treatment sessions, comprising the 30-session index. For maintenance ECT courses, the ECT supervisor writes the orders for treatment. This may be designated to the ECT practitioner after a documented discussion.
How often we should revisit the capacity to give consent? How often? When they are incapable of giving consent and the deemed consent is for 15 treatment.
Right.
The patient may regain.
So according to MECU, the recommendation is that consent is good for 15 treatments or 6 months, whichever expires first.
But that's a different question. In the interest of time, I know it's thing late. That's different. Yeah. Yeah. So if we move ahead to communications and documentation, well, what we're trying to do at other sites is it depends on the frequency of the ECT, how often we should leave a progress note. So every time we see the patient, this in your package is a draft of the outpatient maintenance ECT progress note. Depending on how frequent it is, every time you see the patient, you make a comment on yes, they're still capable, or no, they're still incapable of providing consent, and so we're making it quite frequent that way because it could change, right? If they are, that's a good point. Well, we've not. I mean, things are murky enough, so we've took out the continuing ECT phase. So it's either index or the acute treatment. And once that's you've achieved remission, whether it's wellness or full or
Your conference is scheduled to end in 2 minutes.
the then the index course is over. Then you're into maintenance. And no, it's everything after index. Well, in the definitions, it does talk. We do add, and we didn't go through this because we thought everyone would. We shouldn't have assumed perhaps that it's just to prevent recurrence of psychiatric symptoms and maintain remission. And we just kept it. Yeah. How would we define?
But isn't it the MRP that decides that the treatment phase is finished and you've now moved on to maintenance? Isn't that a decision that the MRP makes? And when he or she writes the order, that the order changes
Conventionally.
from this is the index course to this is now the maintenance course.
And maintenance is pretty fluid. I mean, you can go from once a week to, every 2 months, 3 months,
Do you have any suggestions? No?
Mm-hmm.
Now, in the interest of time, I know there's a couple more sections on prescribing and patient transfers and communication documentation. We're hoping to get your feedback on. But what we'll do instead is probably ask you to take a look at those 3 sections and just email me in response to an email that I sent out a while back, and I think you're all on that list. Any thoughts around that? Because the the prescribing part is fairly straightforward. We're trying to 15 treatments, another 15 if you think the index requires it. Maintenance, it makes sense. Patient transfers, that part there was some discussion around how we would do that if one site had some availability, how we move patients to that site, and how do we communicate with the physicians so that no one's caught off guard. I don't want someone to start ECT and then some patient from another site lands on their slate and they don't know anything about it. So we want to have some clear expectations for communication around that. How do we do that? But also, because we're moving a bit more regionally, the sites just have to be a bit more flexible, I think, in the next little while to accept people that aren't from them. And the other issue is the tertiary sites. When they moved from Riverview here, I don't know what the agreements were, who would do their ECT. I don't actually know. I was going to ask Nigel, but if you have any ideas, that would be useful to establish those conduits more formally. I think the communication and documentation piece is fairly straightforward, but again, any input would be useful. Any last words? Comments? Thank you so much. I think please. So what were those 2 documents you were referring to?
Yeah. No, March 3rd. March 3rd.